Thank you everyone for calling in to our Tempus breast cancer webinar. My name is Dr. Calvin Chow. I'm the Senior Vice President of Medical Affairs at Tempus. And today's discussion topic is next generation sequencing in advanced breast cancer, exploring recent clinical advancements. We're going to have really a dynamic discussion with our two faculty speakers today, Dr. Cynthia Ma and Dr. Massimo Cristofanilli. And the discussion is really around how to use next generation sequencing in guiding breast cancer management. And so I'd like to introduce them both. Dr. Massimo Cristofanilli is Chief of Breast Medical Oncology at the Sandra Edward Meyer Cancer Center at Weill Cornell Medicine. And Dr. Cynthia Ma is a Professor of Medicine at Washington University in St. Louis, the Siteman Cancer Center. So thank you both for being our faculty speakers and discussants today.
Thank you.
Thank you.
So our agenda here is listed here. Really, we will be exploring the potential clinical utility of both solid tumor tissue next generation sequencing and liquid biopsy sequencing with circulating tumor DNA. We'll talk about when each of our faculty discussants use which type of test or whether there may be some complementary nature to these tests and how they may inform treatment decisions and help in managing patients, particularly in the ER positive, HER2 negative cohort of the subgroup of patients. And we'll talk specifically about the post or during the first line CDK4/6 inhibitor setting and how patients are managed as patients receive those therapies, and in the second line setting as to how the sequencing may influence subsequent treatment choices. And we'll talk about ESR1 alterations, and we'll also talk about some of these management strategies based on biomarkers. And then lastly, we'll conclude with a little discussion about the future directions in breast cancer, both a reference to some guidelines today and also some emerging gene alteration biomarkers that could be of importance and may be represented in clinical trials. So before we get into that, I'd like to just make sure that this audience is aware that Tempus has actually produced some data based off of the large molecular database that Tempus has, both incorporating the tissue testing and liquid biopsy testing, the XT and the XF assays. This was actually a paper that was just recently published in JCO Precision Oncology. Minetta Liu was the lead author, and it was in 2022. What it was an assessment of the concordance rates between the solid tumor next generation sequencing and the liquid biopsy ctDNA sequencing at different time points as represented in our very large database. And we actually looked at different time points as represented on the chart on the left, the bar chart, where patients were assessed that had both the Tempus XT and the XF tests at different time points, less than 7 days apart, from 7 to 30 days, 30 to 100 days, more than 100 days and less than 365 days, and then in total, less than 365 days. This actually shows in blue those mutations or alterations that were found by both tissue and liquid biopsy sequencing. In the green, those alterations that were found only by tissue testing, and in purple, the alterations were found only by cell-free DNA or circulating tumor DNA. And as you can see that as the time points become farther apart, there seems to be a greater level of discordance. And I suppose that's expected, but this is nice to be able to see the magnitude of these differences. I think that the point being also that one should not expect 100% concordance at the less than 7 day time point. And I think it's been documented not only here, but in other data sets as well, that there may be good reasons for some of these discordances. And then on the right, we see the individual genes that are represented in these analyses. And again, those that were found in both tissue and liquid liquid alone and tissue alone. Let me just stop here and ask our panelists here if is this something that we should expect, and might there be good reasons for what we're observing here? Cynthia, why don't we start with you?
Sure. I think this data is pretty consistent with what we see in the clinic. I think, if you look at the comparison, between tissue and blood even if they were collected pretty closely, less than 7 days apart, if you only do ctDNA sequencing, you may be missing 20% of the variants in the same genes even. So, and then vice versa. So I think some tumors may not be shedding the DNAs, tumor DNAs to the blood. So you may have some sensitivity issues with ctDNA. And then, however, also ctDNA may be representing a more diverse can capture the heterogeneity of mutations from different sites of the tumors. So that may be capturing things you may be missing when you biopsy just one site. So I think that's maybe contributing to that. And with longer duration, longitudinally, ctDNA offers kind of a better way to look at tumor evolutions over time. Under pressure, tumor would evolve, and I think this is what I would expect.
Great. So Cynthia, if I understand you correctly, you're actually using both the tissue and the ctDNA testing at the initial time point of when you first test a patient. Is that right?
So when I see a patient with metastatic breast cancer, especially those with HER2-negative metastatic breast cancer, I do tend to, get a tissue next-gen sequencing as well as blood next-gen sequencing tested. Although, for example, for ER-positive breast cancer, our standard is CDK4/6 inhibitors, I still would like to know what I'm expecting the second line might be. So, for example, if I maybe seeing PIK3CA mutations, then I would be thinking about our next line could be a PI3 kinase inhibitor. And if I see some resistant, mutations like RVs and things like that, I might, following the patient more closely. And just because of this, sometimes you may be missing with one assay, one tissue versus the blood. That's why, I tend to get a baseline, but I do repeat them at the time of progression because, especially with ESR1 mutation, you may be getting that after progression.
Great. Thank you. And Massimo, your comments about these data, and also maybe if you could reflect on what you do in practice as that may be related to these observations.
Yeah, no, obviously this is, as Cynthia just mentioned, is reflecting what has been seen also in other studies. We certainly have the need for both at some point. It can be at baseline or later, depends on how people practice. Some physicians feel that because baseline and newly recurrent tumors will receive CDK4/6 no matter what, may not be relevant at that point to perform an NGS test either for the tissue or for the blood. But I think it's important, as Cynthia mentioned, because some tumor will not shed later. You don't know if these mutations that you're looking for, actionable mutation, will be present in either one. Most important, I think this study showed that the tumor evolves, and we didn't know before using NGS routinely in the clinic that there was a possibility that actually the mutational pattern, especially for some clones and some genes, will change. And now we know that some of these clones may be responsive or resistant to the therapy that we use every day. So I think the longitudinal monitor with cell-free DNA and eventually repeat biopsy when it's appropriate with new sites of disease is important to give the full opportunity, the full view of all the opportunity we have available with approved drugs, new drugs in clinical trials, some of the mutations or the list of mutations that are potentially actionable. You see some on this right slide, PI3K mutation clearly has been now actionable since the approval of alpelisib, but there are others in the same pathway, like AKT, for example, and PTEN, they may soon become actionable. So the more you know upfront, as Cynthia mentioned, the more you can plan what happens after the first line, what happens when the patients have some evolution. And of course, we may even talk about the allele frequency of some of these clones and how we can determine if some of these mutations are really going to be a good target for the next therapy.
Thank you very much. Let's ask a very pragmatic question here. For metastatic breast cancer patients in general, when do you actually do the sequencing or do tissue and or liquid biopsy? What do you do first? And when do you do it? Do you wait until the time point of after, say, failing a CDK4/6 inhibitor in an ER-positive, HER2-negative patient, or do you do it up front when the patient is first diagnosed? Massimo, why don't you answer that first?
So we talk about patients with new recurrence, not the de novo patients, and with several scenarios. So if you have a biopsy of a liver, of a lung, or lymph node, you want to do the tissue and the blood. If you have bone lesions only, and sometimes this is what we see in patients with metastatic breast cancer, it would be difficult to run an NGS on tissue. So your blood test really is a major driver for the decision process. So the lipid biopsy is the major NGS test. So I think in general, you want to do as soon as possible, except for the de novo patient where probably there are no driver mutations outside the one that we know, and there is no resistant mutations yet. So I think this is for ER positive. Of course, if you extend it to the other groups, I think for the HER2 positive group, we have so many targeted therapy, they may not be necessary to jump to the NGS upfront, because we know that some trials are looking into the role of some mutation in the resistance for anti-HER2 targeted therapy and the possible evolution. And for triple negative, there started to be some actionable mutations that I think we should consider, like AKT mutations. Of course, you can have TMB if you believe that for immunotherapy, this is important for breast cancer. And in other possible mutations that are for clinical trial enrollment. So I think that the portfolio of possible mutation in breast cancer that includes triple negative breast cancer is certainly increasing at the point that you should perform a tissue when you have a tissue biopsy that can be analyzed with preserved DNA, and otherwise with or without cell-free DNA, and monitor over time.
Great, thank you. And Cynthia, how about you? When do you actually do the testing, and which tests do you use?
Yes, I think I definitely would, do the next-gen sequencing at the time of progression on CDK4/6 inhibitors. And I, a lot of times we'll have to do ctDNA analysis because, especially in patients with bone metastasis, for example, may be difficult to get a repeat biopsy. But I think I also usually when I see a patient, even with newly diagnosed metastatic breast cancer, I do the, I even order the next-gen sequencing at that time as well.
Okay.
Although for ER positive cancer patient, it doesn't alter what I would do, but I think it helps me to plan ahead. And sometimes tumor tissue sequencing of the, metastatic biopsy that initially diagnosed the patient can give you information on, like, for example, PIK3CA mutations that I don't have to wait, for the sequencing to come back at progression. So I think that's helpful.
So it's just a timing advantage to have the result when you need it.
Yeah.
Once you fail that CDK4/6 inhibitor, you know what to treat next. Okay, great. So let's go on to the next additional study from Tempus. This was actually a subsequent study that was done, and the larger study was done in 4 major cancer types: lung cancer, prostate cancer, colorectal cancer, and breast cancer. And this is actually just representing the breast cancer cohort. This was updated and represented at San Antonio 2022. And the first thing that I think on the left, if you look at the rate of actionable alterations, it's actually reasonably high. And I think that, PIK3CA is quite common. HER2 is actually one of the genes here too. So I think it's not unexpected that we do have a reasonably high rate of actionable alterations. And we'll talk a little bit about some of the less common ones later. But on the right, I think what's notable is we see a pattern that was also reflected in the larger data set of the four major cancer types. And that is that, again, a large of all the patients with actionable alterations found, 58% have those alterations found by both tests, tissue and liquid biopsy, 22% in tissue only and otherwise not found in the liquid, and then 20% in the liquid but not in the tissue. And this can vary based on the cancer subtype, but I think by and large, we do see this kind of discordance again across the different breast cancer subtypes. And it again represents something we saw in the earlier study that was in the Mineta-Liu publication. But let me just stop here and ask Cynthia, and I mean, looking at this, perhaps this might even be a little larger than I would have expected, but any comments on kind of the magnitude of discordance here?
I think, this is consistent with the previous data. I'm not too surprised.
Okay, great. Okay, great. So I think that this is very consistent with that earlier data. We're going to get into now some discussion about the clinical utility of tissue and liquid biopsy testing. I'm sorry, I'm going to move on to the next topic, which is really now about the ER-positive, HER2-negative setting post first-line CDK4/6 inhibitor. And I think that this particular study was informative and interesting, presented in San Antonio 2021 first, and then subsequently published in the Lancet Oncology 2022. And to my knowledge, is I think the first demonstration in any cancer type of the potential utility of using ctDNA without evidence of radiographic progression to track a mechanism of resistance that can emerge that could potentially trigger consideration for switching therapies. So Massimo, would you comment on this particular study and how this was designed and what the findings were, please?
Absolutely. I think this is an important study, as you mentioned, because ESR mutation, since the description in 2013, 2014, first discovery, and then the relationship with AI exposure, since that observation in the metastatic breast cancer, estrogen positive, exposed to high as a high percentage, I draw the attention to see how we can use that information. Of course, the information that we use now, as you know, is for drug development, targeting best therapy that can target some of the variants that are absolutely not sensitive to the therapy that we have, particularly for Western. But this study actually asks a very different questions, and a question that in the field of liquid biopsy is very relevant. What's the clinical utility, the actionability, how we are going to change the outcome of a patient with this acquired mutation of resistance if we make an early switch? And this applies now to multiple different research questions with liquid biopsy. So these are patients that started on first-line AI in palbociclib, and they were following every month with essentially a digital PCR ESR mutation detection method, and then after 2 months. And then they noticed that the percentage of detection of ESR mutation at baseline was very low, around 3%, even though this patient eventually did worse if they had a baseline ESR mutation. But for the patient that did not have, when they found that they have an acquired mutation during the follow-up, they were randomized to receive essentially fulvestrant palbociclib, changing the molecular targeted therapy, in this case, fulvestrant versus ESR versus maintaining. And this was only in the patient that did not clear evidence of progressive disease by imaging. And you can see that the results are demonstrate that you can have a significant improvement or delay the progression when you change to fulvestrant early based on just on ESR mutation detected by molecular tests without an obvious clinical progression. And this is now obviously being brought to the clinic in order to develop a new agents in this field, in this particular space, who we can potentially establish as a new way of practice, as a new standard of care, treat the mutation or the molecular recurrence before the clinical recurrence.
Great. And Cynthia, I believe that this is also something that has led to additional trials. If you would you like to comment on that?
Sure. So similarly, so the phase 3 study for another drug called camizestrant. So this is SERENA-6 trial, exactly kind of similar to this study. There's a screening phase. Patients who are taking aromatase inhibitor plus either palbociclib or abemaciclib, they're eligible to be screened for whether they have ESR1 mutation or not by Guardant 360. And then if they were found to have ESR1 mutation, then they're eligible to be randomized to receive either, continuum of care versus switching or, kind of switching the aromatase inhibitor to camizestrant, which is a selective estrogen receptor degrader, to combine with palbociclib, essentially kind of switching the AI aromatase inhibitor to the camizestrant. And the trial is double-blind, placebo-controlled. So I think the outcome of that trial would really help us, to put this in clinic, as Massimo just, said, changing our standard of practice using molecular relapse rather than imaging relapse.
Great, thank you. This also led, in the sequence of this data coming out, another important study was this Emerald phase 3 trial of elacestrant monotherapy versus standard of care endocrine therapy, pretty much in the same setting. And they actually did some analyses at different time points. I'm sorry, segregated by patients who actually were treated with CDK4/6 for different durations of therapy. So Cynthia, would you like to present this particular study and what we learned from that?
Yes. So Emerald is a phase 3 study of this selective estrogen receptor degrader called elacestrant versus standard of care in patients with metastatic ER-positive HER2-negative breast cancer that progressed on 1 or 2 lines. So essentially, this is a second line or third line setting, and all patients have to have had prior CDK4/6 inhibitors. And this is the trial that established the FDA approval for elacestrant in this setting. So if you look at the overall population, the improvement seems to be modest. However, when you look at the prior duration on CDK4/6 inhibitor, to analyze, you really can see the impact of giving elacestrant versus the standard of care in improving the progression-free survival. So why would we want to look at the prior duration on CDK4/6 inhibitors? I think the reason is to use that as a gauge for their endocrine sensitivity. So for example, if the patient was only on CDK4/6 inhibitors for less than 6 months, likely they have more endocrine resistant disease. But if they had longer duration, for example, at least 12 months or even longer, at least 18 months, then you would have more endocrine sensitive disease. So just illustrates that these patients, if you give ER-targeted drug like elacestrant or other endocrine therapy, that they would be more responsive. So if you look at the curves, so on the top is patient with ESR1 mutated. At the bottom are all patients. So in ESR1 mutated population, you can see that elacestrant, which is a top green curve, the PFS is consistently better regardless whether the prior duration of CDK4/6 inhibitor, whether it's shorter or longer. But in those who had longer duration, like at least 12 months, for example, the PFS was over 8 months. And those with at least 18 months, I believe, was almost over a year on single agent elacestrant. So a similar trend in all patients, although the benefit is less obvious when you compare to those with ESR1 mutated. So this is important, as you can see, with this very tolerable SERD, that you'd be able to just use single agent in these patients.
Great. Let me just ask, since this drug has just been approved very recently, have you had any experience yet in using this drug, and how do you use it, and how do you identify the patients, and how do you use the drug?
Yes, so I think I would take into the consideration of the prior duration on CDK4/6 inhibitor to see whether in the second line setting, even if a patient has ESR1 mutation, if they had at least 12 months of CDK4/6 inhibitor, I think this is a very attractive approach, just monotherapy to limit the toxicities. Otherwise, you'd be giving combinations with either everolimus, if not PIK3CA mutated, or in combination with, you have to compete with like fulvestrant plus alpelisib in PIK3CA mutated. Those methods or those approaches are more toxic. However, in less endocrine sensitive population, I might not use this drug even if it has ESR1 mutation. Yeah, I'd like to hear what Massimo.
Yeah, Massimo, how about you?
No, I think first of all, everything you say is obviously very important, because the selection of treatment, particularly a single agent after progressive CDK4/6, is very important based on molecular testing. And clearly, if you have a patient that's been on CDK4/6 for a long time, and we know how this patient do not like to go into chemotherapy, you don't want a more aggressive therapy. So we try to find everything possible that we can, delay that moment. Now, imagine that in these patients, you have a cell-free DNA where you start to see essentially the major driver, the new mutation appear in ESR mutation with a certain allele frequency. I think those are the patients where potentially you can use this particular therapy at assessment. I've only studied recently in one patient and had an indolent disease, has been on CDK4/6 for a long time, and obviously it was not a perfect candidate for alpelisib. We know that alpelisib is not the easiest drug to give to patients because of comorbid conditions. So this can be a drug, for example, for driver mutations, particularly in region ESR newly progressing. And I think the future, though, is even possibly looking at this drug in combination. If you look at this graph, this Kaplan-Meier, the first part, the patient progress very quickly. There is a group of patients progress very quickly. And if we can imagine that this drug that is so effective in ESR mutants can be combined with another effective drug, maybe we can have even a larger benefit. And I'm sure that the goal will be eventually to move this earlier, because many of our patients are exposed in adjuvant to aromatase inhibitors. So this endocrine resistant, primary endocrine resistant patient that actually develop, progression during NAI and probably an ESR mutation, that will be the perfect setting where I will consider eventually a combination. And I'm looking forward to this type of trials and see what this drug and other drug in this space can do.
Okay,
Yeah,
great.
I think one thing to add is, there is a Elevate trial, is a phase 1/2 trial testing elacestrant in combination with a variety of different targeted agents, like what you're mentioning, like alpelisib, everolimus, and CDK4/6 inhibitors, and there's so many other trials ongoing with a bunch of different SERDs.
Excellent, thank you. Maybe just also as a pragmatic question, so the drug is only indicated for patients with ESR1 mutations, is that right? Okay, so despite the bottom set of graphs, in terms of finding these patients, is there a value to monitoring patients maybe before radiographic progression, as we saw in the PATA-1 study, if they're found earlier? And maybe if you could just give me some pragmatic understanding of how do you practice, how do you manage patients to identify these patients for switching from that first-line CDK4/6 inhibitor plus AI therapy? Massimo?
Yeah, as we know, this estrogen receptor positive patients are the one with enriched in mutations, either founder mutation or later resistant mutations. So these are the perfect candidate for a monitor with a cell-free DNA with blood-based NGS. And then the identification of these mutations, different variants and different polyclonal mutation in some of these genes, actionable genes, is what drive our choices. As was mentioned before, we are not at the point yet that we can change or we will change based on just a cell-free detection without radiographic progression. But certainly we can reach our clinical trials that are looking at targeted combination with targeted agents. We can include some patients with ESR mutation or PHK mutation with the approved agent at this point. But I think this is going to rapidly change. And maybe when the proof of concept is established, we all feel that we need to practice in a different way. And this would be addressing the molecular recurrence before you address the clinical recurrence.
Okay, great. Okay, well, thank you. Let's move on. I'll just make brief mention of a poster that was presented also at San Antonio this last year. And this is really just to help illustrate the large number of gene alterations that could be found when testing a patient in the ER-positive, HER2-negative metastatic setting after patients receive CDK4/6 inhibitors. Actually, in this analysis, there's a comparison of patients who received a CDK4/6 inhibitor versus those who did not receive a CDK4/6 inhibitor in the metastatic setting for these patients. Of course, as expected, we do find a higher rate of ESR1 mutations in the CDK4/6 treated group. And then there are other alterations that are also found at different frequencies, as noted in this second bullet point here, and as shown in the graph. The two graphs represent on the left those that were found by the XT tissue sequencing, the different genes, again, with CDK4/6 and without CDK4/6, and then by liquid biopsy on the right. And so I think that, a number of these genes are known to be potential mechanisms of resistance to a CDK4/6 inhibitor or hormone therapy. I think that for illustrative purposes, this was something that actually captured some interest at the meeting because of the sizable number of patients represented here. Are there any particular genes that may be worth calling out here, Massimo, in terms of what we know about the biology of potential resistance mechanisms?
Well, I think the FGFR genes and FGF are being related in different reports to resistance to CDK4/6, to endocrine therapy in general, and this may be, I think there were some drug development in that space. I see the P10 is an obvious with the same MAP kinase pathway. So this has already been reported and clearly is what is going to bring maybe to some additional drug approval in the space with the Capitello studies that was presented at San Antonio. And this will clearly increase our availability to target the agent. So these are the one that seems to be the most obvious. We've already discussed about ESR mutation.
Yeah. Cynthia, any comment from you about some of the genes here that were noted?
I think, I agree with Massimo. Those are the common ones. Rare ones like RB1, you see that there, as well as like NF1. I think there are trials like being targeting NF1 mutated cancer as well, and RB2. So these are, I think, very helpful.
Great, thank you. Okay, so we've had this discussion. I'm going to go ahead and move on to this case. This is actually your case, Cynthia. Would you like to walk through what?
Okay. Yeah, sure. Yeah. So this is the 65-year-old woman. She presented initially with de novo metastatic breast cancer. Breast tumor, also a bone metastasis. So she was initially started on CDK4/6 inhibitor with letrozole and palbociclib. So 2 years later, she progressed in her liver. So that's when a liver biopsy was performed. That's when she, the sequencing was done. So on the left side is a report of the XT solid tumor. She also had blood testing as well. So that's kind of the normal sequencing. She has metastatic ER-positive, HER2-negative cancer. I'm sorry so that's just one thing. Yeah, and then so at the time of the progression, because of the PIK3CA mutation, she was able to get on fulvestrant and alpelisib. To note, kind of I want to draw your attention to this particular mutation of PIK3CA. Actually, this is not one of the 11 mutations in the companion diagnostics, but indeed, she did have a response for 7 months. So I think that kind of illustrates a more comprehensive look of the gene is important. And then when she progressed after this lines of treatment, because she also was found to have a high tumor mutation burden, so she had a TMB of 17.9 or 3, and this is considered high because more than 10 is eligible to receive pembrolizumab as a tumor agnostic indication approved by FDA. So she was able to receive pembrolizumab monotherapy, and she's receiving that. She continues to receive that now. Have had that about a year now. So I think the sequencing study has really helped her care.
Great, thank you. Is this finding of high TMB something that you find not uncommonly, or is this something that you find more often? Generally, how often do you see this?
Yeah, I think for ER-positive breast cancer, this is not common because the tumor mutation burden tend to be low, but if you look for it in your patients, you would be able to identify a few, and that they would, because pembrolizumab by itself is so tolerable, I think this is a good option for them. Great.
Well, thank you for sending us that case. So I'm going to wrap up here and maybe ask you, Massimo, to walk through this particular slide. This is, I think, just a collection of biomarkers based on current guidelines that are deemed actionable. Would you like to comment on what we have here?
Yeah, especially when you look at the breast cancer, some of these mutations or some of these alterations may be rare, some other more common. We talk about PI3K mutation, one of the most common, if not the most common actionable mutation in breast cancer, and certainly for now in ER positive. We look at germline mutations that may be expanding in the future to ATM and others in PALB2, but for right now it's BRCA1 and 2, and hopefully in the future also somatic BRCA mutation can be included in this list. We've all known about PD-L1 expression, different antibodies and different level of expression, but certainly an important predictive biomarker for immunotherapy for triple negative. Very rare tumors, a very rare alteration with gene fusion, NTRK and RET, BRAF also in some cases, very unusual though. The TMB was just reported. I think it's clear that there could be a few type of tumors. Seems like the lobular cancer has a higher TMB than ductal cancer, but not in the numbers that were seen in this particular case reported by Cynthia. And of course, MSI is usually seen very rarely a baseline. Sometimes you can see the report in patients who have extensive treatment and progression. And then they're too low. We all discussed it. There was a whole session in San Antonio. Is this a different subtypes? What are we dealing with? We would like to define this even better with NGS, and hopefully we can get to that point very soon. But for now, it's associated with a specific therapy, of course, CDXT.
Great. Thank you. On the HER2 low front, I think that would you say that this is something that you would want to wait and first use your endocrine sensitive therapies and make sure that the patient has gone through that first?
Absolutely. I think the Destiny-4, the approval was in a population was refractory, essentially endocrine refractory, has received a number of different therapies. So will not be very early or even second or third line therapy. But I think in general, we are comfortable to say that when we need chemotherapy, we have a lower HER2 expression. That would be probably the setting where you start to use an HER2.
Great. Okay, thank you. And then Cynthia, I'll let you comment on this next slide, which is actually some emerging biomarkers and potential patients that might be identified for trials. Anything notable here that you'd like to comment on?
Sure, yeah. So for the HER2 mutation, this frequency in the metastatic setting actually is a little higher than the primary setting. So I think the 2% to 7% sounds good, especially those with lobular cancer. I would really look for this one. Actually, in NCCN guidelines now, the HER2 targeted therapy with neratinib, with fulvestrant with without Herceptin is actually in the guideline that you can reference to for your patients. But there are trials still ongoing that target HER2 mutation, for example, even with trastuzumab or TDXD. So there's a ETCTN or NCI trial looking at that. And so the other mutations, I think, are very close to be approved, hopefully, AKT inhibitor. So here, the AKT mutation, it happens, about 4% or so in ER-positive breast cancer. Although, we will see what the indications for capivasertib, which is the AKT inhibitor shown to add to the benefit to fulvestrant in the resistant setting, endocrine resistant setting. Another relevant mutation gene would be PTEN, because PTEN is a tumor suppressor, actually negatively regulates the PI3K AKT pathway, and PTEN loss can be a mechanism of endocrine resistance. So it could activate the pathway, and then so AKT inhibitors, I think, would be a good option for that as well. So there are ongoing trials, also maybe selecting patient based on, whether they had PTEN alteration, and others like CMET amplifications, MET inhibitors are being tested. FGFR amplification, especially the FGFR1 or 2, they're more common. They're increasingly being kind of drawn our attention for CDK4/6 inhibitor resistance. So there are trials assessing whether FGFR inhibitors would help. Others like CDH1 inhibitor, Wnt pathway inhibitor for CDH1 mutations, and MYC amplification with BET1 inhibitors. I think these are all, these are just some of the emerging biomarkers, but potentially there are other biomarkers. I had a patient actually yesterday had ALK translocation, actually by your Tempest testing. I was looking for trials for her. She has metastatic ER-positive HER2-negative breast cancer, and actually there is a trial for an ALK inhibitor in all solid tumors. So I was excited to know that.
Was that found on RNA or DNA?
Yeah, no, on RNA. On RNA.
Great. Okay, well, I thank you very much. That was a great discussion. So I just want to wrap up with the point that really at Tempest, we have a comprehensive set of tests here that are very useful in breast cancer. The XT, obviously, we talked a lot about the 648 genes by DNA, and the whole transcriptome RNA is a part of that same sequencing procedure. And that is very useful for detecting many of these rare gene fusions that could be important to identify. We do have data that was not presented here that shows the advantage of the RNA in finding some of these gene fusions and splice variant alterations that can be found otherwise missed by DNA. This, of course, includes also a tumor normal matched approach that is particularly important in being able to more definitively identify those somatic alterations that can be known to be coming from the tumor as opposed to perhaps incidental germline findings. That is something that I think does differentiate our test a little bit from some other labs that don't perform this procedure. The XF plasma ctDNA 105 gene test is also very complementary, as we discussed earlier, to the tissue test. And it can be ordered alone. It can be ordered as a reflex if tissue fails, so that one doesn't have to bring the patient back. If a tube of blood is sent in for the tumor normal match, that same blood can be used for the autoconversion instance. or it can be done concurrently or in a complementary fashion if ordered by the physician based on clinical needs. The XG test we haven't really talked about, but I think Massimo, you referred to BRCA 1 and 2 by germline, which does point to the potential opportunity for PARP inhibitor therapies. And this is something that is represented by the hereditary cancer panel, XG or XG plus, 52 or 88 genes. For those patients who need germline testing, that is available. And the XE test is really a research-oriented panel that mimics the XT in many ways, but obviously includes the whole exome. And then down at the bottom, there are some algorithm-driven tests by some of the artificial intelligence work we've done. There is an HRD-based signature in breast cancer. It's actually simply a DNA-based loss of heterozygosity assessment, but in other cancer types, we actually run RNA to make a prediction of HRD, and that is something that has been useful for some patients. Tumor of origin is another RNA-based signature test that has been helpful for identifying patients with cancer of unknown primary to guide the probabilities of the origin of particular tumors. And then there are two pharmacogenomic tests, DPYD and UGT1A1, that are particularly useful for patients who may be receiving 5-FU-based therapies or capecitabine for DPYD, and for UGT1A1, irinotecan or the sacituzumab may be influenced by patients' metabolism of those particular drugs. And then, of course, the IHC tests for immunotherapies, MMR, and PD-L1 are all represented here. So to have everything in one platform, one point of ordering is one potential advantage that Tempus offers with its portfolio of tests. And the data that actually is received is all, of course, aggregated and presented back in a particular single hub that allows easy access and longitudinal tracking and management for the cancer center. So I'll stop there, and I think that we're just about out of time. I know that there were a few questions that I don't know if we have time for in the interest of time here. So I would invite anybody to simply email us if you have follow-up questions that would be happy to answer. But I'd like to thank you both, Cynthia Ma, Massimo Cristofanilli, for joining us for this program and for being our faculty. And I thank all of you on the line for listening to this program. Again, any questions, please feel free to email me. And we really appreciate your attention, your interest in Tempus. Thank you so much.